All right, we're going to go ahead and get started. Welcome, everyone. It'll take us just a moment to get everyone set here. Terrific. So first of all, thank you to everyone who is joining us today. We really appreciate having you with us. My name is Rachel Vreeman. I'm a global health pediatrician and a health services researcher. Most of my own research work is focused on children and adolescents who are living with HIV in poor parts of the world, particularly in sub-Saharan Africa. I'm currently the director of the Arnhold Institute for Global Health at Mount Sinai and the chair of the Department of Global Health here at the Mount Sinai School of Medicine. Our institute, the Arnhold Institute, is an academic institute affiliated with Mount Sinai that develops and evaluates global health solutions that can be replicated at scale. And while we specialize in global health systems and research related to them and how to better implement them, I would say it's probably never been more clear how much work there is for us to do to strengthen health systems, both here in New York and also with our partners in other parts of the world. We're incredibly excited to launch this series today, although we certainly wish that it was not being caused by the pandemic that it is. And this is going to be the first in a series of such remote webinars that we have that people are welcome to attend. I'm delighted and really honored to welcome joining us today, Dr. Carroll. I've known Aaron for quite a while. He's both a colleague and a friend. He is a professor of pediatrics and the associate dean for research mentoring at the Indiana University School of Medicine, where he's also a vice chair related to health outcomes research and a vice president for faculty development in their research institution, the Regenstrief Institute. Dr. Carroll's research focuses on how information technology can improve care, particularly for children, as well as specifically on health policy related to issues in not only healthcare financing reform, but also how our national health systems work and don't work. We're particularly lucky to have Aaron today because he is known across the country for his writing and work related to health systems and what's working or not working with them. He writes for The Upshot, which many will be familiar with, is a New York Times column where he looks at data-driven issues related to healthcare. He has a really well received and highly lauded YouTube channel called Healthcare Triage, which has won numerous awards. He's written a book, most recently a book called The Bad Food Bible, which talks about all the reasons why maybe bad foods are not so bad. And as it happens, Aaron and I have a history of writing 3 books together about medical myths. And usually it's our job to talk with people about all the science for essentially why they don't need to be worried about 95% of the things that we worry about related to our health and our bodies. So usually we're on the other side of this, I feel like, after writing a number of books and talking about all the reasons why we don't need to be so afraid. But in fact, we are in a very different place right now. So Aaron, after essentially being the New York Times expert on telling people that they don't need to panic, what is the scientific evidence that puts us in such a different place right now, telling us that now is absolutely the time when we need to be very, very worried about this pandemic?
So it's funny you bring it up that way, because I think, I don't think I'm betraying any secrets. It was a couple of weeks ago, I got an email from one of my editors at the New York Times, like, do you want to write this piece that was almost saying, yes, we got to do something about this virus, but don't we also want to worry about this? And I wrote back and I said, I have spent 6 years here, telling people like, calm down. And I absolutely cannot write this piece because this is the one time we cannot do that. We have to freak out. I shouldn't say freak out, but it's time to get concerned. Mm-hmm. So the bottom line is that we haven't seen a pandemic like this. We have not seen a virus that is this infectious, that is this dangerous, for which we have no treatment at all since 1918 or 1917. Like nothing since what most people call the Spanish flu has anything been this serious. There have been flu pandemics, but We have treatments for the flu. We have vaccines, and we have a natural immunity built up to flu in general, so that it's never truly novel. Most of us have been exposed to flu at some point, but there's no immunity to this. And it's the rate at which it's transmitting and how dangerous it is in terms of how many people are seriously afflicted and perhaps potentially die is just completely new to us. And you can see that it's overwhelming healthcare systems around the world. First through a couple countries in Asia, China obviously first, but it's now working its way across Europe, and clearly in the United States now, no one is seeing this more closely than New York City. But we just are not prepared. And still today, people are not taking this, and when I say people, I mean broadly, are not taking this quite seriously enough. We're already talking about when can we stop doing what we're doing without any good data. We're pulling arbitrary dates out of the ether in terms of when we can start going back to normal. And we're still on the upswing. We're still seeing a doubling every couple of days. It will not take that many days until we are in crisis in more places than we are right now. And so this is amazingly disruptive. It is potentially really, really dangerous, and not just, not in terms of health, but also the economy and everything else, and somewhat unprecedented in all our lifetimes, because we haven't seen anything like this in a century.
Sure. And I'm here at Mount Sinai, obviously in the middle of New York, in the middle of New York City, where not only is New York currently the real epicenter for the US in this, but in New York City, our health system is very much at the forefront of dealing with this pandemic. We, as of this morning at Mount Sinai, we had 613 COVID-19 positive patients in our hospital. 123 in the ICU, 75 more under investigation, so probably close to 700 patients. We still, thankfully, as of the current capacity, have about 60 open ICU beds, but they're rapidly converting to open additional units as fast as possible to make decisions and try to figure out if we can use ventilators for more than one patient and so on. And in the New York governor's press briefing, actually just before this session, they estimated that New York City is close to 18,000 known cases currently. It's about it's a little over 30,000 for the state of New York. So obviously, the numbers here are very bad and continuing to look bad in that way. And we're still seeing with those numbers, recognizing we're not testing everybody, probably around 10 to 12% of those who are known to be positive are needing to be hospitalized. A solid 3% are ending up in the ICU. So estimates for lots of hospital beds, lots of ventilator needs and really critical care. And of course, really thinking towards what this means to actively surge our healthcare workforce, which we're all very much in the midst of. So I'm curious, as you think about so we're very much in the middle of this, but we're also really recognizing that this is something the entire United States is going to be dealing with quite soon, even if you're not in the middle of it quite yet, as well as other places. What do all these terrifying numbers mean for healthcare systems in the United States? What do we need to be worried about? What does this look like for the US healthcare system?
Problem is capacity. We have the most expensive healthcare system in the world, and we therefore often believe that we must have the biggest healthcare system in the world. But our capacity in terms of infrastructure is actually far behind what other comparable countries would have. We have fewer physicians per population than most other countries we compare ourselves to. We have fewer hospital beds. We do have a decent number of ICU beds because we focus on high-end stuff. So we were a bit better prepared than other countries with respect to how much we have in terms of intensive care, but we still have a limited number of ventilators, and we've absolutely overwhelmed our sort of resources with terms of personal protective equipment in many areas. The bigger issues, however, are that, and the biggest concern to the healthcare system is how rapidly we could overwhelm our capacity to provide care. Because while we have a lot of ICU beds, hospitals don't stay in business by keeping them empty. And so they were reasonably full before now. They were full with patients who had flu or other issues. They were few with people post-op or been through trauma or whatever else has been happening. They were not empty and waiting for this. They were already pretty busy. This the numbers you're citing are, we're closing in on capacity now with respect to what it sounds like is just COVID infections. And if you're doubling every few days, it will not take days to hit capacity. And that's the biggest concern, because what happens when we hit capacity is that, the biggest first thing is then deciding who do we treat and who do we not treat at, full bore maximum capacity, like who gets the ventilator and who does not. But the bigger problem is that when all the beds are full with COVID cases, what happens to everyone who's sick for other reasons? What happens to the heart attacks and the strokes and the trauma and people who have cancer? When we're canceling procedures left and right, what we define as elective is going to get broader and broader and broader, because it's going to come to mean whatever can possibly not be done today. That will have downstream effects for health for people with a variety of both chronic and acute conditions. Those are not usually baked into the cake of the dire calculations that are being calculated right now. All you see when you see the big scary charts and the curves and the healthcare system capacity and the number of people who might be affected or who might potentially die from infection, they're just looking at strict COVID infection. No one's doing the downstream calculations of what does this overwhelming of the healthcare system potentially mean for people who have other issues that can't get the care they need. What's also going to happen when healthcare professionals, because we can't protect them enough, start getting sick and get removed from the population? We'll see a downward spiral in terms of an increasing number of people who need care and a decreasing number of people who can provide it. None of this is to panic people, but it's important we take this incredibly seriously and bring all the tools that we have to bear to give healthcare professionals and healthcare facilities that are caring for them everything they need. They're on the front lines. They're the ones taking the risks, and they're the ones who are doing this. And we have to sort of put as much capacity and help into that as we can. The response of the federal government has not yet been there. Everybody watches your governor's press conference every day, and it's clear he's feeling it, and it's clear everyone in New York is feeling it. But the rest of the country is not quite yet. And we don't want to get to the point where the rest of the country is feeling it the same way before we actually start to act, because every day we wait is a day harder to catch up.
Absolutely. Absolutely. I want to pause for just a second. I neglected to mention in the beginning to people that we are going to take questions, but we're going to talk a little bit first. There is a box that you should be able to see at the bottom of your screen that says Q&A. Please feel free to write questions in there as you have them, and we'll go through some of those questions after we talk for a little bit more. So please feel free to put your questions in there, and please do put it in the Q&A box. It's easier than the chat for us to manage that way. So, certainly, as you're describing, I think there are a lot of huge challenges when we think about healthcare systems management and priorities right now. Some states like New York are facing those really urgently, but other states we hope will be having a little more advanced time to start working on, meeting those priorities. What do you think should be the top priorities there for healthcare systems in particular?
Preparing for the coming storm, and I think most are. And I think they're trying to do that. They have to get, I think, also protecting their healthcare workers and environments is incredibly important. And I think, again, I'm not seeing a lot of laziness. It's please. I mean, but the problem is I'm not sure that everybody outside of the healthcare system gets how bad this can get. I mean, we're not totally focused on the stories of Italy and Spain, but they're the cautionary tale. They're already, overwhelming their capacity to provide ventilator care. There are anecdotal stories of physicians who are breaking down just because the stress is just absolutely overwhelming. You're starting to see those in the United States, but there just isn't yet this everyone's in this together mentality that's probably going to be needed in order for us to sort of beat this back. People talk about World War II and how there was the sense that the country had to join in and that all industry and everyone had to work together for the war effort, that we had to all contribute in some way to get, that's where we are. But still, we're not there. There are too many pictures of people in spring break. I love Disney World as much as anybody, but that picture, from last Saturday of the final fireworks, where there must have been tens of thousands of people packed in like sardines, and they were going to get on planes and redistribute back across the United States. That's a nightmare. Just horrible. And that was a week ago. So it's like a week and a half, I guess. But we're not yet as a country to where we need to be for like a national pause to really get to where we need to be to flatten the curve. And we're not yet mobilizing further than anecdotal stories and really bringing everything we need to bear to provide healthcare systems with the resources that they need, the technological resources, the protective resources, the personnel resources, everything they're going to need in order to care for us as we try to weather this.
Yeah, and I think it really reflects too how the United States, for all the incredible strengths of its healthcare system, has lacked a coordinated public health system from the beginning. Therefore, when you're responding to something like this, as hard as our public health departments and groups are really trying, we're already behind from that standpoint, and how our care does not typically integrate across all these levels of communities.
Well, anyone who reads me regularly will know I'm not someone who regularly touts the United States healthcare system as phenomenal. It's not in many ways. We are incredibly fragmented. We are not coordinated. Hospitals compete often instead of cooperate. Our models are not necessarily built to share data, to share information, and they're certainly not built for prevention. They are built for taking care of acute cases, which is good in the sense that we are prepared, as I said, with ICU beds. The problem is the wave coming at us is completely inadequate. But our public health infrastructure is woefully inadequate. We have been dismantling and lessening our ability to prepare for pandemics. We don't invest in public health measures and the things that we might do to detect and move resources around and really know what's going on. We have a ton of money and we spend it incredibly inefficiently. And we don't get the bang for the buck, even in health, that we should, let alone public health, where we are woefully inadequate. We can talk about the $3 trillion that we spend on healthcare every year, but a tiny percentage of that is actually public health or prevention. It's all for, mostly tertiary care and a lot of outpatient care that will serve very little good in this. So, I bristle at American exceptionalism when it comes to healthcare. Every time a politician gets on and starts a press conference of this with, of course we have the best, in the, and I'm like, no, it's almost impossible to predict what thing do you think we have the best? Because the rest of the world does a pretty good job in healthcare and achieves pretty good outcomes. We don't have the best of healthcare systems, certainly not public health, and certainly not when it comes to this. But yet we have convinced ourselves that we do, and that probably is part of the reason why we failed to act.
Sure. So we've obviously talked about a lot of terrible things, and there are a lot of really sobering considerations right now, whether we're looking at the numbers or thinking about the system. But we've promised that we're going to talk about how the world can beat this. So even though I know lots of optimistic people are finding it difficult to hold on to hope right now, there is, of course, a lot of anxiety. But you recently argued in The Atlantic and continue to argue that there is another way, that it's still possible to beat the coronavirus.
Yeah.
How do we do that? What do we need to do to find a way through this?
It's a two-step plan, and unfortunately it involves two different tools that people keep confusing of like which one should we use at the same time. The first thing we need to do is right this second absolutely flatten the curve, and we do that by a national pause, social distancing, at least 2 weeks, everybody on board, get in your house, as much as humanly possible, avoid contact with other human beings. Doing that, it's not rocket science, will prevent the virus from getting from one person to another. And it will absolutely work and slow down the rate of infection and help us to get our breath. And we need to do that until we see the curve start to flatten, that we're safe. Now, New York, I think actually there has been in the last few days a slowdown in the number of new cases, which is good news, terrible overall, because the number of cases is still rapidly going to potentially overwhelm the healthcare system. But these things work. And so we need to do that until we get it under control. But part two is the testing. And not the testing of people who are sick and are getting hospitalized. It's the epidemiologic testing we need to be able to do in the community, incredibly widespread, that will allow us to go back to a more normal way of life. We don't need the testing this second the way that we're ramping it up, which is like, let's test everybody in the hospital. They're sick already. That's not going to get us out of this. Nor will it shorten the 2-week window or even the 3-week or whatever it is, because we have to do that until the curve is flattened. But the massive widespread testing, way more than we've got now, is what will let us identify in the future where are potential hotspots, where are people who are well but in the community being infected, where do we need to do targeted isolation of cases so that we don't have to quarantine everybody, we can quarantine the people who might be infected. That's what the countries that are engaging in suppression are doing. And that's what we need to do in the long term in order to get a handle on this. We are not there, but that's the second part. We can get back to a more normal way of life, but it will require massive investment into both testing and a new public health outside the healthcare institution infrastructure, which will allow us to do widespread epidemiologic surveys to know where this is so that we can act in a more targeted manner. But unfortunately, the way we're talking now is we just keep saying testing's coming soon, or it's ramping up. Every day is better. This company's going to do it. That company's going to do it. But almost all of it is still being run by the healthcare system. We call the doctor when we're sick. The doctor decides if we get a test or not. That's not what will stop this. It needs to be public health, broad, widespread community epidemiologic testing, and we're nowhere near that. But that's what will let us, once we flatten the curve, keep it down low and hold the line until we get a vaccine. Because until we get a vaccine, we will still have this hanging over our head that it could come back and overwhelm us. And we'll need to be careful, and we will need to keep monitoring and do all the testing, but we can at least approach a more normal semblance of life than what we're doing right now.
Yeah. So essentially, I mean, of course, you know, we're saying, and we started with like, there are immediate things the healthcare system really does need to do. You know, we need beds, we need more ventilators.
Yep.
We need to protect our healthcare workers, and
Yep.
PPE, and getting PPE is absolutely critical for that.
Yep.
And I would argue, of course, not just the healthcare system, but this needs to be part of the government response. But that's really almost like the BandAid, right? You're sort of saying what we need to do to actually beat this, to get on top of this, is this much broader, real national pause. And also a massively coordinated testing effort that would be built on a public health infrastructure model.
So imagine like if we were talking about a patient, it's like they might be acutely ill, they might need surgery and ventilation and everything else because we got to save their life today. And then at some point we'll start talking about discharge planning and all the things that'll need to be in place so that they can go home and be healthy. Those tools are different. They are not the same. Like the things we need now to save a life are very different than the things we need over here so that somebody can go back home and lead a normal life. Right today, it's the distancing, it's the isolation, it's the resources that are necessary to save those who are sick. It's to get everything to the healthcare workers, like you said, to keep them healthy. That's the really acute issue. But at the same time, over here, we've got to be building up this testing infrastructure because that's how we go back home. Mm-hmm. And that's how we get back to a normal life. And that's also what we need in the long run to keep, to make sure that this doesn't happen again. It's important to look at, we don't know what's going to happen in the summer. Mm-hmm. It is possible that this will be more like a usual seasonal virus. Mm-hmm. In which case, like flu, it may start to subside as we get to summer and start to look good. That is what happened in 1918. Bad spring. Lots of people got sick. We overwhelmed the healthcare systems and everything else, and it was terrible. And in the summer, it started to look better, and everybody breathed a sigh of relief and went more towards normal life. And in the fall, this came roaring back, and in November, 50 million people died. Like, it's the vast majority of deaths occurred in the November of the fall winter. That's the nightmare scenario. We could do everything we need to do right now, get to the summer, this looks good. The fall could make this look like nothing. And we got to avoid that. And how do we do that? We have to have this detection and isolation infrastructure to make sure this does not come roaring back in an unsustainable way and force us to do all of this again, perhaps even more than we're doing right now. That's avoidable if we take action, but that's not what we're doing today. Today, we got to focus on the acute bleeding issue, and that's part one. And then we have this part two that also has to happen if we're going to move forward.
So we've heard, of course, calls for this period to maybe be shortened. The idea that, you know, the cure here is maybe worse than what is happening with it, or, you know, asking like, are these, you know, are we saving one at the expense of the other in terms of the economy and the virus? How does that play in with what you're saying about how we beat this pandemic?
So no one should be under the, I don't even like to say the word trade-off. Like, look, what we're doing right now has massive economic implications, as we're all seeing right now. It's a false choice, though, to think that the two choices are terrible economy and saving a lot of lives, or losing a lot of lives and saving the economy. I promise you, if we let this thing run rampant and millions, tens of millions of people are sick and millions of people are hospitalized, overwhelming the healthcare system, and people are dying in large numbers, no one's getting on a plane. The planes will not be full. The restaurants will not be full. Panicked people will be sheltering in place, not showing up for work, and we will see horrible economic implications and all the bad things that can come from health. So it's a false choice. Now, if you want to get down to the actual numbers of what it might be and how it would be, I don't know. I'm not a strict economist. I play a health economist, but I'm not a strict economist, so I can't do that. But we don't have, like, it's not like there's an either or. There will be bad economic outcomes no matter what we do. And so we have measures to try to make things better in an economic sense. We need the government to do those things, and I will let you have an expert on to talk about that. But there are things that can be done to lessen the economic impact, and Congress has started to move, but to lessen the economic impact of what is going on so that the pain won't be as bad and we can someday recover if we do all of these other things. But the idea that we can just let this go and save the economy and just lose some percentage of the population is ignoring the massive implications of what would happen when tens of millions of people are all of a sudden acutely ill with a very serious illness. We have not seen anything like that in the United States again in a century. And the economic implications of what would happen would also be dire. And so we sort of really don't have a choice. Now, I know people are freaking out, and therefore, again, they're grasping at straws about what day we can come out of this. And as we said when we wrote that Atlantic piece, that's a false question. The question can't be what day we can come out of this. The question has to be, what do we need to do to get the data and take action so that I can answer that question for you? Mm-hmm. And I need the testing so that I can measure where this is in the community. And then I can tell you which communities can lighten up, which communities aren't there yet, and how we get to where they can be. We can get there, but we need the data first. And to just pick a date and say, this is the day we'll lighten up, where we still don't know where this is and what's going on, we'll be right back here, sometime later.
Sure. So one of the things that we try to do at our Institute for Global Health here, in whatever we're answering, is to really think about more vulnerable populations and how we can address issues of access to care, but also how we might protect and advocate for the most vulnerable among us. How have we seen how this pandemic might disproportionately be impacting vulnerable groups or other unintended consequences, as we try to respond to the pandemic in these ways that clearly the evidence seems to be pointing to? But who else do we need to be thinking about in our midst, even as we, worry and try to respond as effectively as we can?
So there's a bunch of ways, of course, to define vulnerable populations. And, first thing to say is, like, all the actions we're taking with social distancing are, to some extent, to protect vulnerable populations. And in that case, I'm talking about people who are most likely to succumb to this illness in a serious manner: the elderly, the immunocompromised, people with chronic conditions. So we have to care about them because, of course, if they get sick, they're going to have much worse outcomes than if people who are not ill get sick. And unfortunately, I would count myself in the vulnerable population. I'm on immunosuppressants. So we're doing this, as we do with almost all preventive measures with infectious diseases, to protect those who cannot protect themselves. But of course, there's way more ways to define vulnerable populations. And of course, people at the low end of the socioeconomic spectrum are absolutely at more significant risk because, for a period of time, we were just, now granted, I hope Congress is acting as I say this, but we have, it's easy for me, and I don't want to speak for you, but probably for you to say, I'm going to just stay at home and I'm going to, work from home. And my kid's school got canceled and, my wife is, working from home as well, but we'll manage the 3 kids. We'll be fine. We'll have food delivered. Costco will come by, Kroger will come by. It's going to be fun. We can order from a restaurant. They'll deliver it. It's going to be fine. But if you're an hourly wage and you don't have, paid time off, then you might have been asked, do you want to stay home and earn nothing? Or do you want to keep working so your kids can eat? When school gets canceled, as schools are getting canceled, do you have to then stay home and get no paid time off? Or do you go to work and perhaps ask, your child to be looked at by your elderly parents who now are at significant risk? And that's exactly what we don't want to happen. We don't have a safety net to take care of, poor people, first of all, the unemployed, but let alone even people who didn't have jobs to begin with. We don't have childcare. We don't have systems set up. What do we do when we cancel schools and healthcare workers are now forced to say, do I stay at home with my child or do I show up to actually provide the healthcare that people need? Your state's doing a pretty good job, and your city, of actually taking care of many of the issues I just said, but a lot of that has to come from the federal government. Also, what happens when people don't have adequate access to healthcare to know if they're sick? What if they're not adequately plugged into the messaging? They don't have time to sit around and watch, CNN all day, or, follow us on Twitter to know how dire this is. What do we do also when, people just don't know why we're doing this and are therefore going out and exposing themselves? What do we do about the people that have to work in grocery stores? They're frontline just as much, as many healthcare workers are. And so there's a lot of infrastructure that it's easy for people at the higher end of the socioeconomic spectrum, or I should say relatively easy, for them to adapt to this new world. But there's a whole ton of people, if not the majority of people, who are going to have massive economic implications, massive health implications, and difficult choices to make in what was already a system rife with disparities. This is only going to exacerbate them.
Yeah, exactly. I mean, I think, the populations that we tend to not think of in these things anyway are being hit even harder as we consider, the homeless, people in prisons, issues.
They're not even getting, they're not getting tested either. I mean, I can't understand how the entire NBA seemed to get a test, but I'm hearing from people constantly who are ill and can't get it. So it's like, we're not, these disparities always exist. So we should not be naive, but it is absolutely showing them.
Yeah. And I think even issues related to women, as we consider how they might, as they're disproportionately the single parents making some of these incredibly difficult choices about work versus childcare, issues with increases potentially in intimate partner violence that we're starting to hear about. Interestingly, you and I are both pediatricians, and of all things, this virus seems to be somewhat less critical for children, though they are certainly at risk as well. And yet, even in the long term, thinking about how children can be deeply impacted by anxiety, by stress around them, by traumatic events, by these big shifts in their social supports, whether it's resources they were receiving at school or the support from their teachers or their grandparents' roles in their lives, that they're now being isolated, even on that level too. I think there are important impacts in the long term as well that we'll need to really think about.
And loneliness. I mean, there's complete isolation for especially the elderly. But I'd say kids too, they're social animals. And to go from, a life where every day is spent amongst tons of peers to then nobody has got to be, a 180 whiplash. My daughter is living on, Sydney's living on, social video games. Fine. This is not the time in our house where we're cracking down on screen time. That's her sort of outlet. That's how she hangs out with tons of friends and still has a social life. She's still got to do everything she's got to do, but we have come up with new novel ways for people to connect. We're connecting with friends on Zoom, finding things to do and hang out. This is going to be hard. in so many ways, social, health, mental health, economic. You brought up domestic violence, which is a huge issue, which I'm just starting to see get addressed. But, you know, tons of people are homeless. Tons of people are food insecure. This is only going to exacerbate that issue. Tons of people don't feel safe at home for a variety of reasons. And we just told them they got to stay there and do nothing. There's tons of people who are institutionalized and it's significant risk for reasons that are not worth that risk. And we are barely paying attention to the issues which are on fire right in front of our face, let alone the ones that are simmering in the background. And I do think we're going to be dealing with a lot of the long-term implications of all of these issues for a while.
Sure, sure. I'd like to shift a little bit maybe and talk about what this looks like in other parts of the world as well.
Okay.
It's obviously very serious for us here in New York, and other parts of the U.S. are likely to face similar situations soon if they're not already, which some places are. But the Arnhold Institute here, we work with global partners in some of the world's poorest places, and this looks equally scary, I would say, if not more scary, for a lot of other places as well. We have, in particular, a number of partners across Kenya and in Nepal and other places, and we're actively working through what responses are in health systems that are not yet maybe seeing the numbers of cases, but in many of those places, the testing is extremely limited, and they are seeing some cases, and we're starting to see those increase really frequently. And I have spent my career working with patients who are living with HIV, and that's obviously a group for which immune suppression is a huge issue. And as I think about these challenges and what it will look like as this virus is rolling out around the world, which we already see it happening, we're maybe a few weeks ahead of some other places, but as we've seen, in Italy and Spain and China before that, we're all only a few weeks away from this, it seems. So, thinking about places that have even fewer hospital beds and ventilators, have massive questions at baseline of how to provide enough capacity for healthcare systems, it makes those of us in global health really, really worried. And at the same time, I think, even though it's so easy for us to be caught up in our own concern and very real, anxiety rightfully placed about what's happening facing us today, it may seem like just way too much to move forward and think about that for other parts of the world with even fewer resources. But we're thinking about, there's so many places in the world where there's incredible reliance on community health workers and having people who are, going out into the villages where they live, who are not trained healthcare providers in the way we usually think about. They're not doctors and nurses, but they're incredibly vital to how health is maintained in these places. And in the setting of a virus like this, how do we figure out how to balance that? There obviously are big risks involved with this as we're trying to, keep people in one place and not have someone who's going from one place to another, interacting with lots of people. And yet there is likely a critical role for them in screening and testing and getting information out and helping people be connected to resources they need. I would argue that our community health workers are seldom being counted in the in the numbers of people who need PPE, the protective equipment, even when, countries are looking at what their healthcare system is going to need. And really all of that, I think, makes even more important for us where we can to shift the mindset that despite our own panics, that this is not a zero-sum game. It's not just like which country, like the US has the most money and can grab all of the ventilators and all of the PPE, but how can we do things that are actually going to build capacity for everybody? How can we actually get more PPE, made and available worldwide as everybody's dealing with this and everyone needs, that consideration? I think it's easy to get overwhelmed with it, and yet many of these governments now have the opportunity to really take stronger steps to learn from all the collective mistakes and also lessons learned to do the things you're talking about, to have, early coordinated social distancing, to try to make plans to really expand the personal protective equipment and the testing capacity however they can right now. If they can invest in hospital capacity, to do so. And also, really to think about essential medicines. I think about this and am actively thinking about this with our patients in Kenya that we partner with around trying to make sure everybody has a 3-month supply of their HIV medicines. It's critical that they, have these medicines available to take usually twice a day, every single day, not missing any doses is what we're always talking about. And it can be really hard to get more than a 1-month supply in a lot of these places. So, we're asking people, please, 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 like we need to get, a longer term supply of your medicines. And of course, that's true for other conditions, even for basic, what we think of as more essential medicines in places where those are not accessible. So it's sort of think about how governments can start doing that if they have a few weeks of a window, or however long it might be, what can go into that right now.
I mean, look, you've forgotten more about how to do this in resource limited settings than I'm ever going to know. So I'm not the expert in, how that will go. I mean, a lot of the tools are going to be the same in the sense that it's travel limitations to start, because the longer you can keep this out, the better. And again, you would know better than I would how feasible that is and what the implications of that would be. It's easy for me to say, but I don't have the knowledge on the ground. And then it would be social distancing, and then protection of the high-risk people. That's where we start. Luckily, all the prevention measures are low tech. They're still costly in the sense that there are social, economic, mental, all the implications that come with it, but they're low tech. The testing is not. And so ramping up testing to sort of get to a place. But of course, if you keep this, if you're good about social distancing and hand washing and protecting the people who are in high-risk situations, you might be able to keep this low for a longer period of time until we can get to a vaccine. And a vaccine is really, really where this potentially ends. But one, we don't know in a lot of countries that aren't doing testing whether this is there yet or not, because we shouldn't take false hope in the idea that this is not there because we don't have cases yet. If they're not testing, there are no cases. But there still are plenty of steps to be taken if countries can organize and plan and have people working with them who understand how those systems work and what steps they should take.
Yeah, and it's I think a very tricky balance right now, even with things that are, relatively seem low tech or low cost in certain ways in terms of social distancing. It looks very different to be told to shelter in place if you're living in a place without running water. If you don't have electricity, you're trying to get those things to come together on a daily basis anyway, on a few dollars or less a day. And then what that looks like when suddenly not only is your minimal income cut off, but you're also trying to figure out, how do I do this and still go get water, or how do I have that kind of interaction that way? But I think you bring up also though another key point, both for what we're hoping for and dreaming for here, but also as we think about where vaccines and therapeutic options start to get developed as rapidly as possible. We'll have, I guess as a plug in our series, next week, we're doing this on Wednesday with Dr. Adolfo Garcia Sestra, who's here at Mount Sinai, who's involved already in early vaccine trials and some of the therapeutic trials. We'll be talking through some of the things where already they're starting to think through, how can we use plasma from people who've recovered from COVID and have antibodies to it as a potential option for early therapies, and then urgent work to try to get vaccines in place. And joining for that session with him will be Dr. Louise Ivers, who leads the global health group at Harvard or MGH, and will be talking about, apart from her deep experience in Haiti with issues of equitable access to vaccines and therapeutics for cholera, if we do get a vaccine, which we all are hopeful for and pushing for, what does that access look like for other parts of the world? How might we, in fact, ensure that they're available, wherever it's needed, or maybe especially if there are places that need it more than we do. How we work through some of those things. So for people who are particularly interested in that, I think we'll have a lot more on that next week. We encourage people to join, but these are incredibly important questions as we consider this. My apologies, by the way, for all the background noise. I am near to a hospital, and while the streets of New York are quieter than they've ever been, there are literally ambulances going by all the time. Let's switch over to look at the Q&A box for a minute here, and you'll have to give Aaron and I, a break as we scroll through these for a second and start to answer some questions. I don't know, Aaron, if you want to jump in with as we go, and I think it probably is easiest if we.
I'm gonna let you look. If you just want to pick the ones you want, I'm happy to answer anything.
All right, so we definitely are seeing some comments from people who are working with partners globally in terms of countries like Liberia. I think we've talked a little bit about the challenges of the consolidated response when we have such a fragmented healthcare system.
Yeah.
Here's a thought. We've made you try to get on this a little bit, but how do we best coordinate between federal, state, local governments and healthcare systems with such a federalist political system? Any ideas?
So this is, well, yeah, because what we've lost track of is like what is in the capacity of states to do and what we rely on the federal government to do. So this is civics 101, but states cannot run deficits. States cannot just invent stuff out of thin air. They can't print money. And so states just can't all of a sudden say, like, we're just going to buy 30,000 ventilators. The money to do that must come from the federal government, which can literally print money and also has enormous tax infrastructure in order to push the money where it needs to be. States cannot tell businesses, stop what you're doing and start making stuff that we need. That is what the federal government can do. On the other hand, the federal government can't really do a lot, I think, with shelter-in-place laws, and I'm not a lawyer, but a lot of the telling states which businesses can be open or not, that is the state government, and that's why you're seeing states, I think, react in different ways to what is going on. But what we really need from the federal level is like management. Who needs what? Moving the pieces around, pulling in the massive amount of money we're going to need to both lift the economic burden on individuals and people and on businesses, and also to pay for and gather and create the stuff we need and get it to where it needs to be in order for that to happen. And they can move stuff around between states. So that's what we need. It's not like I need the federal government to tell me to shelter in place, but I do need the federal government to create whatever is going to be happy, to create the hundreds of thousands of ventilators we might need, to create the tests, to empower the public health system to start to create ways to do those tests and monitor what's going on. We need them to do a lot of the travel restrictions and monitor and they have done that, monitoring about what's coming in and out with respect to travel to try to clamp down this and do some more distancing. But we need to have a better division of whose job is what. Mm-hmm. And we're not seeing that at the moment. Too much of the way we talk about this is an us versus them, Democrats versus Republicans, left versus right. That is not what this is about. We need a much better discussion of what do cities need to do, what do states need to do, what do hospitals need to do, what does the federal government need to do, and everybody needs to do their part. So the squabbles that you sometimes see between the federal governments and the states is that you do it. No, you do. No. Some things are clearly the job of one and some things are the job of the other, and we should stop fighting about the rest of it.
Sure. So question about thoughts and predictions on the impact on transformation of the US healthcare system 6 months from now, 12 months from now. Might we see a boost in telehealth technologies? Do we anticipate a lot more mental health issues, potential increased suicide rates among healthcare professionals and so on? It's kind of wide ranging, but
I think all of those things, probably. So first of all, yes, there's going to be a real move towards telehealth. Mm-hmm. And in some ways, I think society is going to change in that manner. We're doing this. In the old days, you might have asked me to fly in and have the talk, and I would have considered it, and I would have not been as happy because it's like it would disrupt my life, but that's what we did. I think those days may change where, meetings, face-to-face encounters that don't have to happen might not. And there might be long implications of that. Same thing with health. Why bring in someone who's infectious if you can handle it like this? We're just putting other people at risk. That's always been true, but that's just the way we've handled it. Maybe we won't in the future. I think that the stress on the frontline healthcare providers is going to be massive. It's been a long-term concern of mine. I've written about it widely, that I think we do a terrible job of of caring for the mental health concerns of healthcare professionals. There's a huge stigma on people admitting that they have mental health issues or depression or anxiety, which is why I've tried to be very vocal and forward about mine. But I benefit from being a pediatrician and academic and not caring what other people think. So it's like, that's not, everybody doesn't have that freedom. So we're going to need to absolutely care about the wellness and the mental health of people moving forward. There will be long-term implications from all of this. I think that's going to change the world.
Yeah.
Especially, kids are going to remember this too.
Yeah.
This is happening for a lot of people in a very formative time, and it's going to be with us for a while.
Yeah, absolutely. I mean, certainly that all resonates with me as well. In Kenya, we've been trying out various telehealth platforms for mental health support to try to reach and offer peer support to, for example, adolescents who live in really rural parts of the country who are growing up with HIV, and connect them with other adolescents, and also provide counseling that way. This only exacerbates that issue, and thinking about we all kind of need to figure out options like that with not enough people, not enough resources. How might we connect, recognizing that, simple technology is not the answer here. We need much more big things, but how can that be integrated with our systems? And yeah, there's so much stress right now. I'm part of a physician mothers group on Facebook, which is usually a huge source of support, and the level of deep anxiety among all of our peers is, and as people understandably are, being heroes and heading out from their families to take care of infected patients, not knowing what's happening to them, and yet, the stress for their families as well. Let me keep scrolling here. There are a number of questions, and I want to just recognize these, although I think we'll probably not go into as much of the great difficulties with sheltering in place and social distancing, implementing those in resource limited settings. Some of the issues we talked about, but also, of course, what do you do if you live with 30 people at baseline and you absolutely need to have people working? The issues of shortages in testing kits and so on with that as well.
So,
those are all really important.
Yeah, the goal is for everybody to do the very best they can. So clearly some people, if you live with 30 people, social distancing looks every different. In an ideal world, if you could still shelter in place, then even if it's 30 people sheltering in place, you've still limited whatever's going to happen to inside that thing. And then as much as you can, if someone shows symptoms, they should isolate themselves even further. Stay in a bedroom. Let everybody else cook for you.
Yeah.
They'll bring the food. So some of this is just common sense. This virus is not, thank goodness, traveling through the air down the street.
Mm-hmm.
For the moment, we believe the vast majority of infections are, I have to give it to you. So I could still sneeze it on you or cough it on you, but a 6-foot distance is good enough. So trying even in those situations to spend as much time isolated, and then hand wash. I can't say enough, hand wash. Stay away from other people who are sick. Don't be near anyone else when you're sick. Common sense measures will get us a long, long way. This virus is not smart. It's not ingenious. It's just a virus. And so we can beat it if we're careful. The problem is it's hard to be careful over time. Now, it's harder for people in resource limited settings and who don't have resources. I was adamant that schools can't close down until we figure out how to deliver food to the kids who are on lunch and breakfast programs. Because what are you doing? You got to feed them. I was adamant that we can't shut down schools unless we've got, what are the parents going to do? Can they stay home and get paid? What are we going to do about childcare for people who must work because of where they work? Society can overcome these issues, though. Those are issues of will and money. We have both if we want. It's just a matter of, getting government to act. And this is where, again, that's what government can do. That's what they should do. It still does not fix a lot of the problems with domestic violence. It does not fix the homelessness. But you have seen in some cities, homeless numbers radically reduced in the last week, which shows it was always doable. It's just we didn't have the will until it was a direct threat to us. And then all of a sudden, it's amazing how much progress can be made. So we know that these issues can be fixed. It's just we've often lacked the will or enough of the political body to care enough or willing enough to do it, but we can do those things. So I hear you. These are all issues. No one should ignore them, but I would constantly counter with, we can make that better if we want to, and we should.
Yeah. Yeah. You know, and I want to, add to the list, we didn't specifically note, as I think some people have brought up here, the incredible vulnerability as well of undocumented individuals and families right now. And again, issues where political will and how that shapes how at risk these families are is incredibly important in that area as well, so to mention there. There's a question, we've talked a lot here about how critical testing is, and ramping up testing is going to be to our ability to really beat this virus, to get through this, to know what happens over the next 3 months, the next 6 months, the year. And so again, kind of moving to the issue of how political will, how are we going to handle the cost of these tests, and how should we handle the cost of these tests? Already people are, we're asking about, having received bills for these tests and the barrier that is. What are we going to do about that? What should we be doing about that?
I mean, this is just a no-brainer. It's like, they're just going to have to be covered. They're just going to have to be paid for by the government. Like, we're just going to have to pay for it. In the same way, it's like, yes, no debate. It will cost billions of dollars. Fine. Like, whatever. Otherwise, the other alternative is we just keep sheltering in place until we get a vaccine. That's going to cost trillions of dollars. So, the problem is we keep thinking of this in terms of the usual thoughts of like, well, what's my out-of-pocket copayment going to be? And who's the insurance? And is this in net? And it's like, that's got to stop. It's like, just we're going to have to be doing this. It's got to be a public health thing. They're going to test. They're going to give it to us. We're going to get it. We're going to know. We're going to go. No thought. No, just whatever. And they're going to have to pay. And if we start squabbling about, who's going to pick up the tab and is that fair or not, this or that, then we'll just wind up sheltering in place forever, because it's just, there is no alternative. This is going to cost a lot of money, but guess what? Interest rates are incredibly low right now and the market's in the tank. So there's never been a better time for the government to borrow. And so that's what we're going to have to do. We are the richest country in the world, pretty much. Like, we can do this. Other countries they don't have, as much as we've got.
Yeah, and I think that's where, too, like thinking with a long-term eye on this, keeping up the political will to put the testing in place, to keep isolation in place where needed in a targeted way for the long term, so that if we, this summer, if cases are going down, that doesn't mean like, hooray, this is all finished. We can't have a short-term view for this, even if we, might advocate for some short-term differences in how things are being managed, but that we have to keep thinking about the big picture, the long-term, recognizing how incredibly hard that is for all of us.
And no one should be under the illusion that this will be easy. I mean, we do that, I'm not loving comparisons to the flu at the moment, but we have a hard enough time getting people to get shots these days for diseases we've already beaten. Like, this is why we do that. Like, this is why we try to, get immunized, get up to herd immunity. It's to avoid what we're seeing right now. We can't do it with this, but this is the kind of action it's going to take. This will not be the only pandemic that's ever going to happen. It was easier in the past when international travel and borders, we just didn't go around that much. Now the world is so interconnected. It's just so easy for what's happening over there to influence what's happening over here. Mm-hmm. And that's not likely going to go away. So we're gonna need to be ready for things like this and prepared. And there have been, to their credit, people have been predicting this and talking about it for years and years and years about how we're woefully unprepared. Great. Nobody, it's not like they should, they're gonna be happy that they're correct, but they are correct, and we're going to need to make long-term changes.
So we have a global question from you from Costa Rica. So far, this questioner writes, we have not officially confirmed community transmission in Costa Rica. Does it make sense to move forward a test approach now, or should we wait? We want to use our resources as best as possible.
So, I mean, I would be concerned, and like, part of it is like, you should be seeing cases. Mm-hmm. If you're getting an increased number of cases in the hospital and in doctors' offices of respiratory disease that just seems more than usual, then yes, it's time to start going around. But this is not utterly silent. Like even the New York Times had a phenomenal, there was this intricate display of how this started at the market in Wuhan and spread. Like the first warning sign was a ton of disease showing up. People were sick and they didn't really, put it all together. You're aware now. So if you start seeing disease like that, then yes, it's probably worth, doing some community testing in those areas, to figure out where is this and how widespread this is. You can also, this is when you need to talk to like a true card-carrying epidemiologist. They will know the exact number of tests in a population that you would need to run and where in order to detect community transmission. It's not everybody. They can sample, but they'll know. And so we should be doing that. Like there should be plans for every like you have how many people, how wide are they spread out? How interconnected are they? This is what your testing schemes could look like. And it won't be everybody. It'll be a number. And that number goes up significantly once you're like, now we're trying to suppress. But if it's just for background detection, then it's better. So like, hopefully countries are doing that, and that's how you can get ahead of this.
Yeah, and certainly let's shout out and applaud our infectious disease epidemiology colleagues. You and I both do a decent amount of epidemiologic research and infectious disease research, but we need to be listening clearly to infectious disease epidemiology.
Yeah, like I do a fair amount of media when people say like, well, how many do we need to test? I'm like, that's not for me. Like, no, I can talk about the implications in the health system and everything else, but get a freaking epidemiologist, go get a real epidemiologist, just like you'd say a real economist to figure out, what do we need to do in terms of cash transfers? Like, that's not me. There are people who specialize in all of these things. We've got to get better at tapping expertise for the specific areas of what people are good at rather than relying on the same people to answer every single question on every single topic. That's unfortunately what we do far too often.
I'm a little torn with where to go with our maybe a last question, but I think this is a good one for you, Aaron. Question about how this pandemic might restructure the healthcare workforce. For example, thinking about the huge shortage of nurses, but how people are often dissuaded from these careers because of, loans, lacks of openings, and so on. Is this an example of how the demographic shift in the world towards an aging society, more chronic diseases, is now going along with infectious disease? How might this shift our healthcare workforce, I guess, in your...
I'm a pretty pessimistic guy when it comes to this kind of stuff because we have been woefully behind in recognizing where the weaknesses in our healthcare system is and addressing them. We are shockingly tied to American exceptionalism when it comes to our healthcare system. Maybe this will beat that. Maybe this will be the thing that tips us over the edge and we start realizing we got to address the weaknesses and start to change things. But for how long have we known that we focus too much on tertiary care, not enough in primary care? For how long have we known that the ways that we incentivize and pay for different kinds of care drives us to where that is? How long have we known we have a shortage of doctor services and nursing services and done nothing about it? How long have we known that the insurance system is broken and that we have massive disparities and that so many people can't access care and the cost is the way that we ration? Like, we know, we just don't do anything about it. There's a I can't remember who came up with it, who wrote it first, but there's a saying like, the French love their healthcare system and change it all the time. We loathe ours and refuse to do anything about it. And there's some truth to that. You can pick a country and substitute in for France. Maybe this will be the thing that gets us to act, but it's 16 to 18% of our economy. It's really hard to get, when people are making their living off of this, it's really hard to get them to want to change it. But maybe this will be the thing.
All right, well, I'm gonna just close with a few quick comments. One is to note, I know there were some specific questions about care and resources in New York City and some specific healthcare related questions. I would, as a starting place, point people to Mount Sinai's health system webpage, and in particular for access to telehealth or COVID-related initial stuff. There's a banner at the top you can click on to get into those resources and to look for testing. And also we'll show you how to access the Mount Sinai Now resources, which which has a telehealth option immediately available. So I would point people to that if that's of interest. I really want to thank you, Erin, for taking this time with us. Thank you for everyone who joined in from all different places. We will have another one of these sessions next week, as I said, on Wednesday, April 1st, also at 1 o'clock. We're going to be talking, as I mentioned a little bit earlier, about the development of a vaccine for coronavirus, as well as other therapeutic experimental options that are being developed, and looking at that both from an immediate kind of basic science, what's happening right now with the science, as well as from a global perspective and an equity perspective, what does this look like when we think about other parts of the world who are also facing this? After that, we actually are planning the next week's session to be focused on the impact of COVID on global mental health. You've started to see a number of those questions already, and I would encourage you to tune in for that session the next week if you're particularly interested, even as we all think about, for us individually, the impact of this physical distancing on our social status, but also what does that really look like for the world, for global mental health, for how we move forward in that way. But truly, thank you to everyone for joining. We appreciate your time today. And again, a special thanks to Dr. Erin Carroll for taking the time to share with us today. Thanks, Erin.
Thank you. Thank you.